Okay, I think we are ready to go. So thank you everyone for joining today's webinar. I'm really happy to see such a great turnout today. Before we get started, I did want to cover a few housekeeping items. We have a lot of excellent presentations planned for today. But before we get started, there are some things to cover. So I'm sure by now we are all pros at Zoom etiquette, but just a friendly reminder to please make sure that your lines remain muted during today's presentations. So we will have a total of 4 presentations today. And after all of those presentations take place, we'll be doing a Q&A. So at the end of today's webinar, we will have a Q&A portion. We will have plenty of time for everyone to ask questions and have discussion. Chat can be utilized during the presentation. So as questions come up, if you want to remember them and you don't want to forget, you can go ahead and chat those in and we'll make sure to get to those during the Q&A portion. You can also hold off on your questions, write them down, and ask them during the Q&A portion by unmuting your audio during that time. Post-webinar, you can expect to receive the webinar recording link once it's been posted, and then an evaluation will also be sent out. So that'll happen most likely within the next week, depending how long it takes to get that uploaded. And then there will also be a PDF of the slides sent out as approved by presenters. Okay, and then before we dive into today's presentations, I did want to take a minute for each of our presenters to introduce themselves. So I will go ahead and start. For those that don't know me, my name is Reagan Johnson, and I am the Women's Health Manager at CityMatch. My pronouns are she, her, hers, and I am on the land of the Sioux and Omaha people. And I am going to next pass it to Dr. Sarah Roberts.
Hey, my name is Sarah Roberts. I'm at Answer at UCSF. And my pronouns are she, her, and I am a professor and trained in public health, have a doctorate in public health. And relevant to this work, I've been leading a project about health departments and abortion now for about 7 years. And I am on Ohlone land.
Hi everyone, I'll take it. Hi everyone, my name is Claudia Zog. My pronouns are she, her. I am currently on Kumeyaay land and I am a project manager at Answer. And previous to my work here, I was actually at the Best Baby Zone initiative. So I've worked with CityMatch and I think many of you in the past, so happy to be here.
Hello, everybody. My name is Riza Sia. I am a clinical consultant in the Washington State Department of Health in the Sexual and Reproductive Health Program. I currently am speaking from lands from the Salish and Duwamish people. I have been at the department for 2 years. Prior to that, I've worked as a certified nurse midwife for 20 plus years in the state of New York and here in Washington. My engagement as a professional with abortion activities is around providing pre-abortion physicals, options counseling, and support for families pre and post abortions. Personally, abortion has been part of my own reproductive journey. I wanted to bring my whole self to this conversation as a person and as a professional. Thanks for having me.
Okay, and then Reverend Deneen Robinson.
So here's the funny, I am really nervous because I have just been talking away with the mute button on. So I am Reverend Deneen Robinson. I am super stoked to be here. I reside in Dallas, Texas. However, at this moment in time, I am in New Orleans and I am on the Chitimacha land. And My relationship to this project is I do policy work around sexual and reproductive health, focusing on a reproductive justice framework, particularly as that relates to the whole lives of Black women. So I am super glad to be here.
Perfect. Thank you so much to all of our excellent presenters. We're so excited to have them all join us today for this very timely discussion around abortion and maternal and child health. So I am going to go ahead and kick us off and get us started today. So I will be talking about City Match's journey with abortion. So specifically integrating abortion into maternal and child health, a national nonprofits experience. So here are some learning objectives. I hope by the end of today's webinar and the end of my presentation, you will be able to describe the process for introducing and integrating abortion as a critical component of women's healthcare within maternal and child health. Identify how to break down silos like the ones typically found between maternal and child health and abortion work through the development of key partnerships, and also apply lessons learned and action steps within your own organization. Okay, so next I want to talk a little bit about maternal and child health. So I know most of you joining us today on the call are either familiar with maternal and child health, or in maternal and child health, or have some experience with it. But I do want to kind of talk a little bit about maternal and child health and how it's defined. So MCH is defined as a field of public health that focuses on improving the health and well-being of mothers, infants, children, and families. And this definition is broad and it really can be dependent on the organization. So for example, City Match is an MCH organization, but we specifically call out women as a part of our mission statement instead of solely focusing on mothers. However, as a lot of us know, much of the focus in MCH historically has been on mothers, infants, children, and families. So that leads me to my next point, which is what are the limitations of maternal and child health? So one major limitation is that maternal and child health as a field can be very womb-centric, meaning there is a really heavy focus on pregnancy and birth outcomes. So when there is a focus on women's health, it is often tied to improving her health for potential future pregnancies, or to improve future potential birth outcomes. So even when focusing on pregnancy and reproductive health care, MCH often lacks a focus on comprehensive sexual and reproductive health care, almost never including a focus on abortion. And lastly, MCH and sexual and reproductive health care are often seen as two very separate public health disciplines, even though they both focus on similar populations. So then talking about City Match and our relationship with MCH. So City Match's members are city and county health departments, maternal and child health programs. So historically, the projects and programs have focused on common MCH issues, such as infant mortality, perinatal HIV, and preconception health and healthcare. However, in the last 5 years or so, City Match really has started to broaden their focus and incorporate more of a comprehensive view of women's sexual and reproductive health. So it started with introducing and implementing projects focused on women's health independent of pregnancy, such as the Well Women Project and the Well Women, Well Communities Project, both of which focus on preventive health care for persons identifying as women. And it also included an intentional discussion around abortion and how it fits within the MCH framework, and more specifically within our own organization's work. So now I'm going to talk about the journey our organization has been on for the past 5 years. So I will talk about how our organization went from broadly talking about comprehensive sexual and reproductive health to more explicitly talking about abortion and its importance as a part of MCH. And I will also talk about lessons learned throughout our journey and action steps you can take within your own organization if you're hoping to go through a similar journey. So here's a timeline. I'm not going to go through everything on here, but please feel free to take a look. So this is a timeline of the journey our organization has been on for the past 6 years. So you can see that the journey started in 2014 with the launch of the Well Woman Project, which was one of our first projects focused solely on women's health independent of pregnancy. And you can see that each year we progressed further in our journey with the development of new professional partnerships, increased sharing of abortion content with our members, and also the launching of additional women's health projects. But of course, you can see sprinkled throughout, different struggles came along the way. So looking at the timeline, you may be wondering how we got from point A in 2014 to point B in 2020, and what steps we took. So we started this process by really taking an internal inventory of our organization. So I realized that while I personally was really passionate about including abortion within the MCH framework, I needed to figure out how it fit within our organizational framework. So to do this, I looked at the things that made up our organization's identity. So I looked at our mission statement, our organization's leadership, our past and present projects and programs, and also the language used internally as well as externally, and who our organization serves. So what I found was that some of our organizational identity components aligned really well with incorporating abortion, while others might present some barriers. So the components that really did align included our mission statement, which explicitly calls out improving the health and well-being of women and families, both of which are greatly impacted by the access to and utilization of abortion. Our organization leadership, or our directors, really supported open dialogue and new ideas. And our members are health departments, which for some women in some jurisdictions that have limited access to comprehensive sexual and reproductive health services, health departments really could play a key role in the provision of abortion or abortion services. So some barriers that we encountered. So when I was doing our internal inventory, we haven't had any projects or programs that included abortion, and abortion wasn't something that we openly discussed as an organization. Instead, we often defaulted to the broader terminology instead, so saying comprehensive sexual and reproductive health without explicitly calling out abortion as a key component of that. The next step in our process was to identify our organization's role within this work. So this involved thinking about what our organization could bring to the table. A few factors I considered during this step included our organization's reputation within the MCH field, as well as the larger public health field, our staff's skill and capacity, our current and potential reach, as well as the type of funding our organization relies on for projects and programs. So by reviewing these different factors, it became clear to me that CityMatch could best serve this work by promoting existing abortion research and potentially serving as a partner to organizations doing this work. So while our organization is well respected and trusted, and we do have staff with the needed skills and capacity, it is clear that our funding sources and lack of abortion-specific expertise would hinder us from taking a different, more prominent role in this work. So the last step we took in this process after determining our role was how we could best elevate and collaborate. So how could we elevate the existing abortion work that is being done and collaborate with the experts and organizations doing that work? After we determined that our role would be to promote and normalize abortion conversations within our organization and within the MCH field, versus being the ones to actually execute the abortion work, the next logical step was to determine how we could best do that. So we thought about how we could amplify the voices of experts, elevate the resources and research, and lastly, how we could break down silos and collaborate with organizations doing abortion work. So this slide shows a number of examples for how we engaged our members and associate members with this content. One thing I did want to stress is the importance of partnering with organizations that are experts in abortion and reproductive rights work. It is important as an MCH organization that we realize we do not have that expertise, and instead of reinventing the wheel, we can go so much further by offering our platform, skills, and capacity to impact the work that's already being done. which leads me to this slide, which really further amplifies the need for collaboration. So in 2017, we wrote a City Lights issue that focused on the well woman, and that can be found on our website if you're interested in that and haven't seen it. The quote depicted here states how the MCH field really needs an intentional focus on the three components listed here. So reproductive health, reproductive justice, and reproductive rights. This was a really important realization for our organization, and it did lead to a lot of non-traditional partnerships with organizations that focus on and have expertise in the reproductive rights field, as well as the reproductive justice arena. So as an MCH organization, our focus and our expertise is on the reproductive health component. And this is also the focus and expertise of many of our members, which are local health departments. So this is why identifying your role is important, and why seeking what could be considered, like I mentioned, non-traditional partnerships is really vital to helping to normalize abortion as a key part of women's healthcare and a key part of the maternal and child health field and our work. So before I get into the action steps, I did want to talk a little bit about lessons learned throughout our experience. So when I first started at City Match, abortion was never something that was really discussed. And the first time I proposed a conference session on abortion, it was actually rejected. So that brings me to my next point, which is progress over perfection. So in place of a session on abortion, I was told that abortion could be a part of another session, which more broadly focused on comprehensive sexual and reproductive health care. So while this isn't exactly how I wanted things to go, and I much would have rather had a session solely focused on abortion, this was still progress. So the progress may look different than what you expect, but it's still progress in the right direction. I kept bringing it up as a topic for conversation, and eventually that has led to numerous abortion-focused sessions at our annual conference, as well as webinars and other learning opportunities for our members. And lastly, don't underestimate the importance of internal organizational work. So unfortunately, abortion has been made a pretty polarizing political issue. And due to this, it might not be possible for everyone within your organization to agree on this issue. However, it is important that everyone is able to learn and understand the importance of abortion within the MCH framework, and that a shared understanding within your organization can be reached through respectful and intentional conversation. Okay, and my last slide here are some key takeaways and hopefully some action items you can take within your own organization if this is something you're looking to do. So start by taking an internal inventory of your organization. So what is your organization's starting point? Map out your organization's mission statement, the current programs and projects, internal language used around abortion, your organization's membership or population served, and then also the openness of your leadership to new ideas. How does abortion fit into each of these things? And can you use any of these things as leverage for why your organization should be talking about abortion and including it within your work? This internal inventory should also inform you on the type of approach you should take to have the most success. Each MCH organization will have a different starting place, and there's not one approach that will work for everyone. Next, identifying your role. So what can your organization bring to the table regarding abortion work? What role can your organization play in incorporating abortion into the MCH field? And some things to consider, your organization's reputation. So think about how others within the public health field, and specifically the MCH field, view your organization and its work. What expertise or skills does your organization and its staff have that could help move this work forward? If you are an MCH organization, you most likely will not have abortion experts on staff, but you most likely will have other expertise or skills that could really play a key role in this process. And then as far as your organization's reach, what type of reach does your organization have within public health and within MCH? And think about things such as your members, your social media followings, partnerships, and active involvement with other MCH organizations. Does your organization have the ability to reach a large number of MCH professionals? And then staff capacity. So even if you have the expertise or skills on staff, the ability to reach a large number of MCH professionals and a great organizational reputation, it's really difficult to move things forward if you don't have the staff capacity to do so. And then lastly, funding. So when identifying your role, funding is going to be a very important factor to consider. Think about your organization's funding sources. Is your organization's work dependent on federal funding? Does your organization receive any foundation money? As we all know, it is not likely that you will be receiving federal funding for abortion work. And if your organization relies solely on federal funding, this is going to be important to note as you map out your role in integrating abortion and elevating abortion within MCH. Lastly, determine how your organization can elevate and collaborate with existing abortion work. So if you determine your organization cannot incorporate abortion in its own work, consider how you or your organization can instead elevate the work others are doing in the abortion space. If you determine that your organization can do more to integrate abortion into its work, take a look at those doing abortion work and how your organizations could collaborate together for maximum impact. Not only will your work go further, but it'll also help break down silos that exist between MCH and sexual and reproductive health. So these key takeaways are only a starting point for your organization, but I do really hope that it gets a lot of you thinking more about this and thinking more about the role your organization can play. I think we all can play important roles in really elevating this conversation and moving work forward. So I hope this helped you get a better idea of what your journey can look like and how your organization can have the greatest impact within this space. So here is my contact information. It was also on the save the date that got sent out. And I look forward to answering any questions you have at the end of today's webinar and the end of presentations. So I am now going to pass it over to Dr. Roberts and Claudia. Thank you so much.
Thank you so much, Reagan. Reagan actually ended by talking about thinking about organizational roles, and the focus of what Claudia and I are going to talk about is an effort that we've been engaged in over the past few years to really help clarify and define more professional roles related to abortion, so public health professional roles related to abortion. And we're going to talk about a specific effort that we call Envisioning a 21st Century Public Health Approach to Abortion, a convening of maternal and child health professionals. Next slide. So I noticed just when I was looking through the slides the final time a moment ago that the second bullet point on this, we are skipping that in the final version of the presentation. And that's because since we first drafted it, there's been such dramatic changes in abortion policies in the US, and one in particular. So I'll briefly talk about that to give some context. Happy to share details of any of the research that we've done. I'm happy to talk to anybody about that and share a whole bunch of resources. So we'll talk about some dramatic policy changes in the US, and then talk about what they mean from a public health perspective, and then talk in great detail about this 21st century convening. Next slide. So when we first started doing this work, we were really focused on how many restrictive and non-evidence-based abortion policies were implemented through the health department infrastructure in many states. And that health department commissioners, in some cases, were defending these non-evidence-based restrictive abortion policies in court. That was the case with two major abortion cases that were heard in the US Supreme Court: Whole Women's Health versus Hellerstedt, and June Medical Services versus Russo. And both of those were laws that were not evidence-based, that severely restricted people's ability to obtain abortions, and health department commissioners were defending them in court. Next slide. But just in the past few weeks, there have been some dramatic changes that have occurred in abortion policy in the US. The Supreme Court denied a request to stop what functions as a 6-week abortion ban in Texas. And that law has been in effect for the past few weeks, essentially making it so that people in Texas are unable to obtain abortions if they're further along than 6 weeks. So that is currently in effect. The Supreme Court has also agreed to hear a challenge to a Mississippi law that would ban abortion after 15 weeks. That legal challenge has the potential to overturn Roe versus Wade, which is the law that made abortion legal throughout all US states in 1973. Next slide. Oops, next slide, there we go. So colleagues estimated if Roe versus Wade were overturned, the number of legal abortions would fall considerably. And I think they are working on some recent updates of these maps, but the darker purple color are the places where legal abortions would fall the most. Next slide. So we all may have our own personal or political views about abortion. And part of what I see our role is on this panel is to help us articulate what our roles are as public health professionals. And so I wanted to outline the public health implications of both Texas SB 8, which is essentially the 6-week ban that is in effect, as well as a possible overturn of Roe. And I'm happy to share the citations and evidence that informs each of these implications. So people could possibly obtain a facility-based abortion out of the state that they are in. That leads to increased travel, which certainly has potential health implications in the context of COVID, but also just more risks from long car rides. There are increased costs, and people may have to forgo rent, food, or other day-to-day expenses, and they may be delayed. And while abortions are safe in the first trimester as well as the second trimester and later, as people get further along in their pregnancy, there's a slight increase in complications. Some people may seek to self-manage an abortion. Unlike in the pre-Roe era, people can now do this both safely and effectively, for example, with misoprostol. However, they do risk criminal prosecution. They also may try less safe approaches, such as hitting themselves in the abdomen, and there are physical health risks with approaches like that. And also, again, a risk of criminal prosecution. And then I think the most directly relevant to people who are very focused on sort of a more traditional maternal and child health lens is that people may continue their pregnancy. When people continue their pregnancy because they are unable to obtain a wanted abortion, there are risks from childbirth, which is considerably less safe than abortion. There are short and long-term physical health complications. There's more violence from the man involved in the pregnancy. There's more economic insecurity, as well as child development challenges. Next slide. So if you take nothing else home from my portion of this presentation, I want to make it really clear that public health professional voices have typically been absent from the scholarly and policy conversations about abortion in general, and how health departments should engage with abortion in particular. And at this moment of flux, having that voice out there is incredibly important, as well as preparing your health department about how to navigate and ensure the health and well-being of people who are affected by these changes in abortion policy. Claudia.
Thanks, Sarah. So we're going to switch gears a little bit, but building off what Sarah just mentioned, even prior to the past few weeks, it was apparent that there really needed to, we needed to really develop a vision for what a public health approach to abortion could look like. So building off some of the work we had previously done, we started planning a convening that would bring together a diverse group of people working in state and local health departments and some other partner organizations to really plan for what this could look like. Next slide. So a group of us at Answers led the planning of this convening, and we also brought on 2 trained facilitators to support us. We also brought together an advisory committee who helped us identify participants and provided input to both the process and the content of the convening. Prior to the convening, we sent participants a survey to ask them kind of what led them to participate, if they had concerns about participating, noting the sensitive context of the convening, whether they had any professional experience with abortion, and what activities their departments were currently engaged in related to abortion. We also shared some summaries of research and presented this information via webinars to participants ahead of the convening, which also helped to let folks get to know each other before the convening itself. And the 2-day convening took place over Zoom back in May of 2020. Next slide. The convening had 3 primary objectives, which are here on the slide. I'll quickly go through them. One was to create a shared understanding about reasons why abortion fits into the mission of MCH programs and health departments. 2 was to seek alignment around a vision for what activities related to abortion are appropriate for health departments. And 3, to define the major areas of work needed to translate this vision. Next slide. Here's just a quick snapshot of who participated. There were 36 individuals in total from all regions of the US, and we really strive to have diverse representation. There were 7 state health departments represented and 9 local health departments represented, and 10 different partner organizations, including community-based organizations, schools of public health, and change-making organizations. Next slide. On the slide, you'll see the different values that participants mentioned when we asked what should guide health departments' work on abortion. You'll see that health equity was commonly mentioned, as well as evidence, autonomy, and reproductive justice. When asked to describe the ways in which abortion may fit into the mission of MCH, participants noted that because abortion is an outcome of pregnancy and because health departments serve people who can become pregnant, health departments really should also be able to meet the informational and service needs of pregnant people who are considering or seeking abortions. Another framework that really resonated with participants was the life course approach. So when someone is unable to obtain an abortion, it will not only affect their own health, but their children's health. Next slide, please. So in order to determine which activities would be appropriate for health departments, we engaged participants in a structured consensus process, which essentially means participants voted using the annotation feature in Zoom on which activities they believed were appropriate for health departments to engage in. So if 80% of participants considered an activity appropriate, it was included in the final list. We had multiple rounds of feedback, both during and after the convening, to home in on the wording of activities. And this final list, which was later termed the menu of abortion-related activities, was then categorized by the 10 essential public health services, which is a widely accepted framework for health departments. The full menu of activities can be found on our website, which is linked here, and we're happy to also send out the menu as a follow-up. But for now, I'll just give you a quick glimpse into some of the activities that are on the menu. Next slide. So here are the activities that fell under essential service number 1, and I'll just pull out activity 1E, which is to develop a straightforward metric for health departments to assess the need for abortion services versus the availability of abortion services in their jurisdiction. Next slide, please. For essential service number 3, one appropriate abortion-related activity that was deemed appropriate for health departments is to ensure the quality of informational materials related to pregnancy, including that they're gender inclusive, reflect the nuances and ways people feel about their pregnancies, acknowledge that not every pregnancy results in a birth, and that abortion is a common outcome of pregnancy. Next slide, please. And lastly, just as an example for essential service number 8, an appropriate activity would be to train health department, clinical, and public health staff on abortion, such as providing values clarification activities, abortion 101 training, reproductive justice training, and then just general training on not making assumptions that every pregnant person they interact with wants to be pregnant. Next slide. And lastly, the last objective was to identify major areas of work to move this vision forward. Participants came up with 4 major areas of work. The first is to get endorsements and support from leading public health organizations on the menu of activities. And we're happy to report that since the convening, we've made some progress on this area of work. We submitted an APHA policy statement on the topic. It's currently posted on the APHA website and being reviewed by the Joint Policy Committee. We also wrote a peer-reviewed manuscript that was accepted today, so great timing, about the convening process, and also contains the menu of activities. Participants also recognize the need to conduct workforce development related to abortion, centralize abortion-related research, and coordinate learnings across health departments. We recognize that the pandemic has significantly hindered the ability to move much of this work forward, and appropriately so, health departments are dedicating their resources to COVID-19. And we have really appreciated our conversations with CityMatch and other participants of the convening, such as Risa and Deneen, about what this could look like. And we really look forward to engaging others in this conversation moving forward. Next slide. Just want to give a quick thank you to everyone else at Answer that supported the convening, and of course to all the participants that really made this a reality, including in that perfect transition into Risa. We'll speak to what's happened since the convening.
Okay, thank you, Claudia. I'm excited to be here. I'm talking from Washington's right outside of Seattle. Next slide, please. Thanks to everyone for doing their land acknowledgement. I wanted to also take a moment just to do a labor acknowledgement. We acknowledge that our country and all aspects of its development throughout history have been made possible by the labor of enslaved Black, Indigenous, and people of color. Next slide, please. Next slide, please. Aha. So in the interest of time, I'm going to abbreviate talking about all the slides in my presentation and really focus on my personal aha moments during the convening and how I took that back to Washington State, and sort of give you an example of some things that we're doing at the state level. So thanks for letting me participate in the convening. I do appreciate that I was able to participate, that I did recognize that some states were not represented due to their health departments not allowing them to participate. So I was very fortunate to be part of that. Some of the key aha moments for me as a professional provider, certified nurse midwife, and as a public health worker as well were that abortion is a common outcome of pregnancy. Why that's an aha moment for me at this point in my career, I don't know why, but it really shifted the way I looked at everything. And the data that was presented made an impression on me that 1 in 4 women will have an abortion by the age of 45. That people who seek abortion and those who give birth are often the same people at different moments in their reproductive lives. Over half of people who have abortions have previously given birth. And these were aha moments for me. Even though I have practiced as a certified nurse midwife for over 20 years in 2 states that had progressive reproductive laws, I didn't until that moment really connect the dots between providing abortion services and the larger public health framework, which centers work on equity, access, and optimal health. That the people that we focus on to have safe and healthy pregnancies and healthy babies are the same people that seek abortion services before having children, in between having children, after they complete their families, and for those who choose to live child-free. The second aha moment for me was when they talked about health departments' activities. And I come from a state that I was very proud of, saying we do a lot of work around abortion activities. But after hearing sort of these statements made me feel like we could do a lot more. One being that most state health departments are engaged in some activities related to abortion. However, these efforts largely reflect what is required by law rather than the breadth of core public health activities. The second is that even in environments that support abortion policies, those who want to do more work related to abortion often feel they have to be cautious with leadership or not contradict existing practices. This also resonated with me because it described how our health department operates. We create and follow laws that support abortion services, but we actually, to me, held it in a space that was separate from the work that we normally do in our program, which is the Sexual and Reproductive Health Program, and that we don't fully integrate it into our program work, that it kind of remains a quieter work. Don't make too much noise about it, keep it sort of under wraps, even though we support it as a state. So those 2 things really resonated with me, and I wanted to take that back to our department. So Reagan, I'm going to have you scroll down. I'm going to have you pass all of these slides until we come to, I want to say, keep going. And maybe the next one, I'll start there. I wanted to make sure I was able to share specific examples of what we were able to do on the state level. The previous slides were addressed by Reagan and by Sarah and Claudia, and then also will be addressed by Reverend Robinson. So I will skip that piece, but in summary, it was a way to bring back that information and look at where it fit in frameworks of public health, where it aligned with our Department of Health, where the intersectionality of work could come from other DOH programs or from frameworks that already exist. So those I'm going to skip for now and just focus on the specific things that we've been able to do in Washington State. And one of the most, I think, the most important thing that occurred from the convening was to share out the information. And I didn't share it out right away because it was May of 2020 and we were still doing the pandemic response. We had just withdrawn the previous fall from the Title X program, and our team was redefining our program. So there was a lot going on in the Department of Health, and I know those of you who work at the departments of health, there are so many competing priorities. And how do we keep abortion and sexual reproductive health in the forefront of all these conversations? So one of the things we needed to do was first to share it out to my team. We are a team of 6 people, and to really look at abortion as an integrated part of the work we're already doing, rather than work that we do ad hoc or that we do separate from the work that we do every day. And so I sort of led our team to really take stock and inventory of what do we actually do that support abortion activities, what could we do better, and what can we add on? And I'm all about the small steps forward and the low-hanging fruit. And so it was good to take an inventory. And if I could sort of bucket it in 3 different buckets, I would say that it had to do with information, collaboration, and data. And as far as information, I want to say the strongest part of our program are our partners who we contract out to. So we have 16 partners who cover 90 clinics in Washington state. 5 of our contracted partners perform abortion services, and the rest of our partners refer out their services. And so they hold the expertise on the ground. And so anytime we have questions, anytime we're trying to figure out something, they are the ones who bring the questions to us. They tell us what the barriers are, what the information is that they're receiving, how things are landing in their health centers. And so our relationships with our partners is probably the strongest thing of our program. And as the Texas abortion law was passed, we started to think as a state, what are our partners thinking? Our partners who are experts in abortion services, what are they thinking about? What are they doing? What are they seeing on the ground? As we think about what does Washington state then become, how do we become part of the national conversation on restrictive abortion laws? How can we be a safe haven to states that are unable to have better reproductive laws? Are we looking at things like increasing access to LARCs and emergency contraception? Are we looking at how do we provide prescriptions across state lines? These are conversations that we are currently in that the Texas abortion law has sort of catapulted to the forefront in a lot of ways, and making this a national conversation. And what is the rippling effect throughout our country? The other thing we looked at was our website and our social media. So we have a website for the sexual reproductive health program, but really in the last couple of years, we really had a landing page for abortion. And so that was pretty new to our website. The social media piece, where we wanted to call out certain services, we wanted to make sure people knew what was accessible in Washington state, took a lot of conversation with our communications team at the DOH. And so it was not immediately from our communications side, was not really like, yes, let's do the social media, Instagramming and tweeting, but it was conversations with our team, with communications team around abortion as a public health framework. And I think the biggest thing of the convening was to reframe that conversation so that we could take out the political viewpoints of it and the moral and emotional part of it, and really look at it as a public health framework. And when you turn that conversation, everyone shifts their paradigm just a little bit, so that there's little cracks where you can have conversation that's reasonable, that makes sense, and that in the end supports the mission of the Department of Health. And so we have made some groundwork on that, and we were able to launch some media campaigns. Again, we have pretty strong state laws, and we watch the policies that come through the legislature, and we try to participate as content experts as we talk to our partners on the ground. The updates and trainings, so since COVID started, I started sending out communications every 2 weeks about resources, research, news, DOH news, and all of that. And so part of that is to include anything about abortion, whether it's new research, new data, new training, anything of that nature is just part of the work. Next slide, please. I'm hoping I'm still within my time frame, so I'll talk a little bit quicker. As far as collaboration, I mean, this is something we're all talking about, that we need to stop working in our silos, that we need to reach across programs and reach across expertise to really address a whole person and to address the whole journey, the whole reproductive journey of a person. And so even within our program, reaching out to the perinatal unit, maternal mortality, the STI, HIV group, the drug and substance use group, the adolescent health, we are constantly trying to find where we can do some intersectional work. And including abortion as part of our work makes it easier to sort of collaborate and not, again, hold it separate from the work that we're already doing. So I want to say, as I presented the convening work to the section, I also felt a shift in the paradigm as we presented it as a public health framework. And since then, there has been more conversations just with our team to collaborate, not just with abortion, but sexual reproductive health services in general. And so that is really hopeful for me and our program to sort of work beyond our own boundaries of our program. One of the things that we could do to keep that conversation going is to constantly have standing meeting and touch points with everybody, because as everybody in the Department of Health gets so bogged down with their own work, that's how you get siloed, right? Because you don't look up and go, what's everyone else doing? So having standing meetings on your calendars with people that you feel are champions of the work, who share the same desire and passion for the work, is really important to just keep going, because we're always going to be COVID for a while. COVID takes the precedent of a lot of conversations. And I'm going to finish up with one last slide about, the next slide please, is about data. So all of our work in public health has to be data driven. I want to say this piece is in its infancy around abortion. We have tried to sort of make headway with trying to collect what data would be important to us that would drive program work. I'm going to say we're not really good yet at this, but I am hopeful that we will do better. One of the big good conversations I had was with the person who collects the abortion data at the Center for Health Statistics. So even starting that conversation, to have it at the forefront of someone else's mind, to say, hey, we are starting to look at abortion data in our state. Have you written, is there a report that you all write? How do you collect it? And so those kinds of questions is what has been coming out, but it's still in its infancy. We do have an epidemiologist that works with us and really kind of pulls back the reins and tells us, what are you collecting? Why do you want to collect the data? What are you going to use it for? So those are the sort of specific things we're doing. I think I went over time, so I am going to stop here and punt it off to Reverend Deneen Robinson.
So I've been thinking all day about how I wanted to do this time, and I do have slides, and looking at the time and wanting to stick with the commitment to giving 30 minutes for the Q&A. I'm gonna move to the next slide, please, and talk about how we can engage in this new place that we are in care. Here's the thing. It's new to us, but since the beginning of time, people have been finding ways to have success with pregnancy, not be pregnant if they don't want to be pregnant, deal with challenges around fetal anomalies, et cetera, or deal with having a large family, having a small family, et cetera. And they've been doing these things because it's what's necessary for them. Us getting in their business, quite frankly, is one of the things that has made this complicated. I personally, both as a cleric and someone that is actively engaged in policy around reproductive justice, which includes the right not to parent when one does not want to, ergo abortion access. It is quite challenging for me to hear folks who want this resource, and because of our government's intervention, have found it now difficult. So moving forward, ultimately abortion has to be a part of the continuum of care that we are offering as health departments. And I'm going to talk about why on the next slide. Dismissing, not discussing abortion as an option can result in further damage to the reproductive lives of people who are seeking care. And we saw earlier that someone talked about the reality that When folks are going to have an abortion, they're either going to use a legal means, or they're going to use a means that may result in harm to them. And I believe that if we operate and use a reproductive justice framework, we can alleviate some of the challenges that we have around discussing abortion, around understanding abortion as a part of the continuum of reproductive health care. Next slide. So, reproductive justice is the complete physical, mental, spiritual, political, social, and economic well-being of women and girls. And this is inclusive of trans-identified women and femmes, and non-gender conforming folk as well, based on the full achievement and protection of women's human rights. Next slide. In a nutshell, it's the right to have children, right to not have children, right to parent the children we have, as well as to control our birthing options. That means that we have the right to birth in a hospital or not in a hospital, using a midwife or a doula. And to do this without having to fight systems, and also the right to bodily autonomy. Next slide. So why is this necessary? When we are talking about one's ability to access reproductive health care, it cannot be siloed in any way. We can't just focus on the person who wants to parent. We can't just focus on the baby. We can't just focus on certain aspects of reproductive health care, because it is a continuum. Each part impacts the other. And ultimately, we have to focus on ways to make the life of this person better, to make the life of their family healthier, and to make it so that they are able to engage and have a sustainable community. We cannot participate in isolating this part of reproductive health care because of our own discomfort, because of our own religious ideals, because it's not about us. It's about this person, and it's about their life and what they believe is best for them and their family. And we ultimately have to understand that comprehensive reproductive health care is a human rights issue. And as I said, our personal religious beliefs, they are important for us as individuals, but they cannot interfere with the choices of other people. Next slide, please. One of the things that Sarah and Claudia brought up earlier was SB 8. SB 8 offers us a unique opportunity to look at how we frame the conversation around abortion access. Number one, anyone with this law, not only do you have to have this procedure in actuality when 2 weeks after you discover you've missed a period, but also there's an aid and abet clause, which means that anyone who chooses to assist a person either by providing information, a bus pass, a ride, resources, is at risk for being sued in the state of Texas for a minimum of $10,000. And this is anyone in the state. It's not meant to harm the individual who is seeking the abortion, but anyone around them, even providing food for them so that they're able to take care of the children that they already have, or providing childcare for that person is considered aiding them in successfully getting an abortion. And so it's important that we begin to have this conversation in a very large way, because our silence, our unwillingness and discomfort at placing abortion in the continuum of reproductive health care, quite frankly, is how we got here. When we center the person and understand, get to know them, and look at why they're seeking this procedure, it changes how we look at the choices that they're making. And more importantly, our judgment is ours. It is important that we actively engage in not judging other folk. And if you as an individual are not comfortable with having this conversation, create a referral list so that you can engage someone in community to assist them so that they have what they need to make the best decision for them. Next slide. At the end of the day, here's where we are. All couples and individuals have the basic right to decide freely and responsibly the number and spacing of their children, and to have the information, education, and means to do so. I want to say, as I turn it back over to Reagan, that we as individuals who have committed and made it our life's work at this moment to assist people with accessing maternal and child health care, we are in a unique position to help someone make the choice that is best for them. It's complicated. It's not easy. And our judgment and our unwillingness to actually get all the facts and deal with our biases and discomfort in ways that are not harmful, take away our ability to support them. We signed, whether it was a contract with your employer, or in my case, an opportunity that I accepted from the divine to be an assistant, to shepherd someone through a process. Let's not rob them of all the options so that they can be the best parent that they want to be, or if they don't want to parent, they don't bring children here that they ultimately end up mistreating. And more importantly, that they have every resource that they need so that all the children that they have, that they can do the best job of parenting them successfully and parenting them in ways that not only cause the children to thrive, but that parent to thrive also. Thank you. And I'm turning it back over to Reagan.
Great. Oh, thank you so much to all of our wonderful speakers and presenters. Yeah, wow, excellent job. I want to open up the floor, and if anyone has any questions for our presenters, you can feel free to chat them in. There still are 130 people on the call, so chatting in might be the most streamlined way to accomplish getting a question asked. But you also are free to unmute your line. You can raise your hand or just unmute and ask a question. Just make sure when you do ask your question, if it is for a particular presenter, that you note that. But yeah, let's go ahead and open up the lines and start some discussion. And there was a question earlier in the chat that someone did answer, but I was wondering, Reverend Deneen, if you would maybe want to expand a little bit on the difference between reproductive justice and reproductive rights. And that's actually a common question we get as well when we talk about this.
Sure. So as I was moving quickly through the presentation, one of the things that I wanted to lift up is reproductive justice is not only something that's used to guide and center Black folk in work, but it's also a framework that all of us can use to guide our work. And it's particularly, in my opinion, a necessary framework when you're doing maternal child health work, because it allows you the opportunity to center that individual and make sure that they comprehensively have everything that they need to successfully engage in parenting or not parenting, and parenting the children that they have in sustainable environments. Reproductive rights very simply centers abortion access. It is the right to choose pregnancy or not, to terminate a pregnancy. So it centers abortion very simply, not necessarily the person, but the act. And that is the main difference between reproductive justice and reproductive rights. Rights centers the right to have the procedure, a right to have an abortion, right to have access to abortion care. Reproductive justice centers that individual with helping them make the decision that is best for them.
Perfect. Thank you so much. If there's any follow-up questions, feel free to throw them in the chat. The next question we had was around the Guttmacher Institute. Dr. Roberts, do you want to expand on that one a little bit?
Unmute, I'd be happy to. Yeah, I would say I think Guttmacher does an amazing job fulfilling what I would describe as a public health surveillance role. That for other topics, other health topics, might be done by more government health bodies in some way. They do a great job with their estimates of the numbers of abortions in the United States. And they have a very rigorous process to count them, and then do fabulous estimates also of number of people who have an abortion over the course of their lifetime. So what Risa was describing earlier, so many of those key facts are things that we know from all of the abortion survey work and data collection that Guttmacher does.
Unmute myself. And then Dr. Roberts, there was also a question around, so I'll read the question and then I'll go ahead and let you expand on it. What suggestions do you have for those of us who are exclusively funded with federal funds and therefore not allowed to discuss abortion in our work, but want very much to include abortion in our MCH and maternal health work?
I mean, I would say funding is just tricky. I mean, funding is tricky in terms of being able to do this work. I think it's worth clarifying one thing. I don't think federal funds prohibit a discussion of abortion. I know that there's restrictions in terms of direct clinical care and requirements for people who accept Title X funds that I'm sure people on this call could know in much greater detail than I do. But even the NIH funding, like that has very specific things that you cannot do with it in relation to abortion. There's nothing in that prohibits a discussion of abortion in a manuscript or even in a survey that you're doing in terms of federal funds. The restrictions have to do with whether or not any of that money can be used to pay for an abortion. Or whether any of that research can use fetal tissue. So I think that we tend to apply some of the restrictions that exist in relation to Title X, for example, and apply them much more generally than they actually are. That said, I mean, I think doing a proactive project on abortion when you're entirely funded by HRSA funds that fund you to do a very particular thing, I mean, in the same way, it'd be a problem to devote your attention to doing something that you weren't funded to do. I mean, you know, like a whole other topic, like if you weren't funded to focus on immunization, starting to do that with funding that went for something else would be a problem. But I think we sometimes over apply these restrictions and thereby censor ourselves.
And I was just going to add that one of the things that we talked about during the convening is if you as a person that works for a health department can't do it, you can invite someone in. And that way you're not doing it, you're making space for them to do it as a part of a comprehensive reproductive health care conversation. And they are doing this particular part. And that way you're not doing it. as an organization, you're bringing a co-conspirator in to assist you with that. And then create a resource list. So if you're not comfortable, simply give the individual, hey, here's a list of organizations that you can speak with about this. It's not something that we can talk about, but I want you to have all the facts. So please, let's set up a call right here while you're here so that you can have a conversation with them in a timely fashion so that you can have all the resources to make the best decision.
Also, if I can chime in, I wanted to add to the Title X conversation that the Title X program under the Trump administration had changed what was required from people taking funding. And one of it was the actual providers could not refer or discuss abortion to their clients. That was actually in Title X during the Trump administration. That along with the separation of physical space of doing abortions from your other clinical work was also required. And those are the reasons that Washington State, us being one of 6 states, withdrew from Title X because of those restrictions. And also it went against our own reproductive state laws. So I do see where the chat, Allison George put in the chat that the allowing providers to discuss that was actually part of the Title X restrictions under Trump. That is going to change under the Biden administration, and we will, as a state, reapply for Title X. I did want to ask the chat, Allison George, who put that question in, just wanting to understand the federal funds that you get and what is your state saying? I guess, what state do you live in, and do they have also restrictions around that work?
So I am based in North Carolina, and so which is not known for its forward-thinking approach to sexual and reproductive health. But I think also, personally in my situation, it's a matter of also working with other folks who have so far traditionally been focused on maternal and child health as being about birthing people and babies, and less so incorporating whether people do not want the outcome of a pregnancy to be a baby. So there's also a matter of shifting focus, or in widening our focus among leadership and other folks here. It's not so much just the federal funding as it is how it's been interpreted by leadership so far and what colleagues want to do with it, since I am not leadership at the center that I'm currently referring to.
Yeah, and I would say, it sounds like some of the work that we were doing in Washington State, which was to shift the paradigm, right, and shift the conversation and be more inclusive and understanding and presenting it as a public health framework. And saying what we've all been saying is that it's all part of the reproductive journey of a person and their families. And maybe even that is the lowest hanging fruit for you, is to start changing those conversations and sharing out evidence-based information, new frameworks, outcomes, putting together presentations that speak to public health or to speak to providers or health centers that make sense. And oftentimes, colleagues who work in these areas respond better to data and evidence-based practice and outcomes, so that the conversation can at least start where you're working at. I wish I had a better answer for you, but thanks for the question.
I have a question for Reverend Janine, if that's possible.
Go ahead.
Yes.
Reverend, I have two simple, not simple, but quick questions. One is, what has your response been to African-American Christians who, present to you about their concerns with abortion? And then piggybacking off on that is people who say that, that that white people or abortion is really trying to eliminate our race. Like they're trying to get rid of Black people, and this is just another way to do it. Thank you.
So first of all, thank you for asking that question. In all honesty, the data that we collected a few years back said that 86% of Black folk who are in church more than 3 times a week support comprehensive reproductive health care, including abortion access. Now, as a Black person who understands that we have these outliers who seemingly are the voice for most Black folk in their rigorous religious constructs, who say that abortion is against God, that's going to be their way. And I'm happy to have conversations with them. I find great joy in using scripture actually to let them know that their beliefs are archaic and irresponsible. Also, when it comes to those people who say that white folks are using this as a way to eliminate our race, that is horseshit. Very simply, it has been a ploy over the years that actually white conservative evangelicals have used to get us to vote against ourselves, to get us to participate in situations, policies, politicians, voting for politicians that are against our best interests. And so what I do is remind them of the whole of the person and what they believe and why that's not true, including the conversations around the person who started Planned Parenthood and her beliefs around Black folk and population control and all of that. It's important that in 2021, we look at what's really happening that decimates our communities. And we know by data that when a person has a child and they are in poverty, they visit poverty on 3 generations. So that means that they remain poor, that child remains poor, that the child has virtually no chance of getting out of poverty, and that child's child. And so when we want to look at coming up, if you will, we have to be responsible in our parenting. And if a person has indicated that they don't want to have a child, they should not be punished or made to feel guilty to parent, especially knowing that they are going to be judged by those same people by having too many children, by having children that they can't afford, by having children that they can't clothe, etc. And so we have to move beyond this codependent way of engaging around religion and make the choices that are best for us as people. And those are the things that I interject in those conversations. They are not easy, but because of my own belief in the basic foundational principle of Christianity, which is choice, I don't think anyone has the right to take that from another person. You don't have to like what they do, but are they harming you? You can't take their choice away. Them and God will work that out. I feel sure about that.
Thank you. We had another question in the chat. If any of the presenters can help answer, it is, are there any resources or organizations that can specifically consult with rural health departments to work on supporting abortion services where access to abortion services are limited or far away?
So I can start if they are in and around Texas. Trust, Respect, Access is a coalition of funds and organizations, and we have funds that are located close to borders. I am happy to provide some education services, especially if they are in and around Texas, to help with educating them and to help them get some resources around responding to the transportation reality.
I would just add, I think Reverend Deneen, definitely like connecting with your local abortion funds is, I think, a great idea, especially for rural areas. They know a lot about connecting folks to abortion services, and even just having like an informational chat with your local abortion funds can really get that conversation going. And then also something as simple as just posting on your health department website a list of resources about the closest abortion clinics and information for contacting abortion funds if you need the support. So there's some additional activities in that menu of abortion related activities that I think would definitely apply to more rural health departments as well.
Great, thank you. I have a question I would like to end on for all the presenters, but before I do that, does anyone else, any of the other attendees have any questions? Feel free to chat them in now, or if you want to unmute yourself. Okay, the question I would like to ask all the presenters is, we have spent today talking about abortion, which is a very important and essential healthcare service for persons of reproductive potential. But something I was wondering if you could talk a little bit about is how restrictive policies around abortion, or even kind of the how people politicize abortion, how does that affect other healthcare that women receive? So how does this impact other components of maternal and child health? Because I think that is a really key way for people to bring this into the MCH conversation, is really talking about how we need to talk about abortion, because policies and restrictions, making it taboo, all of these things can impact other components of MCH. So I would love to just open the floor and hear a little bit about this from our presenters today.
So Reagan, I didn't pay you for that. So one of the things that we don't talk about is that according to the World Health Organization, 15% of maternal mortality cases are due to illegal abortions. And so based on that data, we know that people not having access to abortion care definitely puts them at risk of experiencing maternal mortality or maternal morbidity when they actually are prepared to become pregnant and actually try to have a successful pregnancy. They end up dying and they are not able to actually raise the child that they so wanted. And so that's important. The other thing is when folk experience fetal anomalies because of the restrictive laws, they are put in the same position as someone who is looking to terminate a pregnancy because they don't want to parent. There's not an exception, especially in the law in Texas. There's not an exception. And there's also not an exception for rape or incest. And so restrictive abortion laws adversely impact the lives of individuals who either want a parent or not at that moment. And so it's important that we have an awareness of that.
Thank you.
Also, sorry.
Oh, go ahead, please.
Yeah, no, it's also, if we're all looking at the continuum of a person's reproductive life, then any restriction at any point in that continuum causes an effect, right? And so it definitely is worth reaching across program lines. That's something that is hard to do. It's trying to connect the dots for everybody to see that a person's totality is what we're looking at, not just pieces and different experiences. But when you restrict one piece of access, then it's a ripple effect across their whole life. And so it's really a way to shift how we look at healthcare. It's easy to piecemeal healthcare because it's just more digestible, but the reality is people come as a whole person, and as part of, and wherever they are at whatever point in their life, they need to be able to access and have the right to access good healthcare.
I would add 2 pieces on. The first is on a very practical level, a study led by my colleague, Dr. Diana Green Foster, called the Turnaway Study that followed 1,000 people seeking abortion, some of whom were able to obtain the abortion and some of whom were denied the abortion. So it's a quasi-experimental study for people who are thinking methodologically about it. Found that people unable to obtain their wanted abortion had worse physical health outcomes, both in the short and longer term, experienced more violence from the man involved in the pregnancy, experienced more economic security for themselves and their children had more challenges in terms of their development. And so when we think about that, those are direct maternal child health impacts of policies that make it so abortion is out of reach. And then the other way that I like to think about it, I also I'm happy to share the links to the Turnaway study with people who are interested. And I wonder if we could maybe send links to some resources when we send the slides out after the webinar. Is I also do work on substance use in pregnancy. And the policy making in that area, we found that the policies related to substance use in pregnancy actually tend to harm rather than help. And so I've done a lot of work to look at the origins of those policies. And there's certainly a history in terms of history of racism, the racist war on drugs, but there's also abortion politics. And abortion politics have been so central to the formation of those policies. And so instead of thinking about how do we have policies that actually support the health and well-being of people, pregnant people who use alcohol and drugs and support them in terms of caring for their children, we're stuck in abortion politics in that policy area as well. And I think that's also incredibly harmful for maternal and child health.
Going last, I think Sarah just said what I was going to touch on, but I'll just add a few more things that really, and reiterate things that we already discussed. But for me, coming into this world from more of an MCH lens, I really believe the life course theory can really be a guiding framework for how abortion can fit into maternal and child health. And reiterating the fact, and what I think we spoke to this earlier, is that people seeking abortion are the people who are also giving birth at different points in their lives. So really refocusing on that and centering the birthing and pregnant people. And then again, I also think we talk a lot about like allostatic load and stress and its both emotional and physical effects on the body. So I think when you aren't able to have a service that you want, those effects are increased. And I think being able to talk about that and bring that into the conversation, as it is, I think, already really embedded in the MCH conversation.
Great. Thank you so much for expanding on that. So we still have 89 of you on, which is awesome because we are a minute past time. So I really appreciate everyone joining. Thank you for all your thoughtful questions and discussion. Of course, a very special thank you to all of our excellent presenters. I'm hoping to continue this conversation, hoping to bring some of them back for a conference session, and just really hoping for continued thoughtful dialogue around this as we move forward. Check your inbox in the next week. You will see a link to the webinar recording, a PDF of the slides, a evaluation. Please fill it out. Your feedback is important to us. And then I will also include all of the presenters' contact information and any resources discussed today in that email. So again, thank you so much, everyone, for joining. What a great webinar. What a great discussion. And hope you all have a great rest of your week. Thank you so much.
Thank you all.
Thank you.